and then the calcium level is again restored to normal. Right? Again, so this is that same talk in different ways. I say it in pictures. The picture is more than 1,000 words, right? Right, okay, so
You said right.
PTH stimulates osteoclastic bone structure, increases renal absorption of calcium ion, I told you already, inhibits renal phosphate and bicarbonate reabsorption, and it does one more thing. It activates 25-hydroxy D. So it stimulates 1-alpha hydroxylase, and that is the enzyme. You know, when you take vitamin D and you absorb it, it goes straight to the liver. Liver slaps 25-hydroxy into 25th position, and the vitamin D is released back into the circulation as 25-hydroxy vitamin D. Then at the kidney level, under the influence of PTH, 1-alpha hydroxylase put the second hydroxy group in the first position, and that's how you form 125-dihydroxy D. That is the real active form of vitamin D. Remember all that, right? Okay. Okay, so everything I just talked about. PTH, bone, from intestine, from the kidneys, from 125 to release phosphate, to absorb calcium from the gut, to activate it to restore serum calcium. So let's talk about hypoparathyroidism. It could be congenital, very rare. Acquired, very common. When it is congenital, there are two types, subtypes that you should know about. I'm not never going to test you on this. You just need to know it, because somebody might throw it at you one day. I don't know. There is something called the Judges syndrome. The Judges, you have not done pediatrics yet, right? Okay, maybe they will talk about it. I don't know. But there is something called the Judges syndrome. It's an autosomal dominant chromosomal defect associated with neuroendocrine, renal, and cardiac abnormalities. That's all there is to that. What I want you to be familiar with more is this polyglandular autoimmune syndrome. There are two types. The first one is called Whittaker syndrome, and it's a syndrome of candidiasis, hypoparathyroidism, and Addison's disease. It is an autosomal recessive genetic defect in autoimmune regulator gene, AIRE gene, carried on chromosome 21. This gene product mediates immunological tolerance. You see, I'm reading this slide, right? How would somebody pitch this at you in an exam? They will give you a patient with current resistant candidiasis, and a routine physical exam will show low serum calcium. Okay? So the female with resistant candidiasis and routine blood test will show low calcium, high potassium. That is Addison's and hypoparathyroidism. That's how that will be pitched at you, right? Then the second one is called the Schmidt syndrome. That one is hypothyroidism, hypoadrenalism, parathyroid, and it's just a bunch of multiple endocrine deficiencies. That is why it's called polyglandular autoimmune syndrome. Whittaker and Schmidt's. Honestly, if there is anyone you should be more aware of, it is Schmidt's, because it's actually the most common polyglandular autoimmune syndrome. Schmidt syndrome. Schmidt's is the most common one. All right? If anything, somebody might ask you that. No, it's not going to be me, I promise you. Now, let's talk about the acquired. That is the there is fun there. The commonest cause of hypoparathyroidism, honestly, is surgery. You send somebody for thyroid surgery, and remember the parathyroid gland are in the back. And when they're operating, everything is bloody and red. So they take it out inadvertently. And then your patient end up with
Parathyroid.
Hypoparathyroidism. And then the other way is somebody develops a parathyroid adenoma. And the surgeon goes there and take out the parathyroid gland, and somehow they misjudge, and your patient will end up with hypoparathyroidism. You see, what I'm talking about here is too premature. I'm ahead of myself. You can cross it out because we're going to talk about it later on. But basically what it is that when you have parathyroid adenoma, that is a champion tumor, right? It's producing all this parathyroid hormone. And because it's doing it, it's going to suppress the surrounding normal parathyroid tissue, right? When you now take that adenoma out, the bones are going to be like, whoa. They want to recover because all this time they've been dissolving themselves to respond to the PTH to maintain serum calcium, right? When the bones now, when you take out the adenoma, the bones reverse and they want to rebuild so fast. And because they want to rebuild so fast, they precipitate hypocalcemia. And that becomes a major syndrome known as hungry bone syndrome. We'll talk about it further on in the class. And then the next most common cause of acquired hypoparathyroidism is autoimmune hypoparathyroidism. Most common non-surgical cause, right? These are the two main. If you are going to see a case of hypoparathyroidism in your life, it's going to be surgery or autoimmune. Magnesium deficiency, your patient will present first with hypokalemia, and you will correct it. So they never really get to develop hypoparathyroidism. And the mechanism for magnesium deficiency is inhibition of PTH secretion and the action of PTH on the bone. Again, infiltration by amyloids, hemochromatosis, Wilson's disease, and neck radiation. Okay, you can do neck radiation for goiter and end up with hypoparathyroidism. Got that? How does it present? It presents with hypocalcemia. Okay? How does hypocalcemia present? Circumoral paresthesia, so numbness around the mouth. Muscle fatigue and weakness.
Yes, sir.
They have cramps, a lot of cramps, skeletal, abdominal, laryngeal cramps. They have this incessant muscle twitching, and they can actually have frank seizures. And because of the spasm around the larynx, the voice box, they can actually develop stridor. But what everybody expects to know is carpopedal spasm, positive Chbostek sign, and positive Rousseau sign. Okay? So, this is Chbostek sign. You tap on the facial nerve, and because it's applied to the face, you can precipitate spasms of the orbicularis oculi. So by tapping on the facial nerve in front of the ear, the patient will blink as many times as you tap. Okay? That is your Chbostek sign. Trousseau is you're taking blood pressure, and once you inflate the cuff above a certain level, you precipitate these spasms in the hand. It's called carpopedal spasm. If you leave hypoparathyroidism and hypocalcemia for a long time, you begin to precipitate premature cataract. It can cause Parkinson's disease because of the calcification of the basal ganglia. You begin to get brittle and ridged nails, dry and scaly skins. All of these, none of these is really specific, but you must remember fatigue, spasm, tuberosity, and drusen. Okay? You do an EKG. What is obvious on this EKG? Can somebody tell me? What do you expect in hypocalcemia on EKG? Prolonged QT. See how long the QT interval is here? It's almost 3 beat boxes, right? Hyperkalemia. Prolonged QT in hypocalcemia and short QT in hypercalcemia. Okay? So, potassium affects the height of the fluid. Calcium affects the QT interval. Okay? Not the QRS duration, QT interval. Now, this is a very important slide, but it's also very confusing. So let me explain it to you. Just listen carefully. What would you see in the lab in a patient with hypoparathyroidism? You will see hypocalcemia and hyperphosphatemia. But there are other reasons why somebody's serum calcium might be low and somebody's serum phosphate might be high. So in order for you to say that the low serum calcium and the high serum phosphate you're seeing in these patients is due to hypoparathyroidism, you have to exclude these other causes of hypocalcemia and these other causes of hyperphosphatemia. You got that slide? Okay. So, I'm going to digress a little bit now to talk about causes of hypocalcemia. The commonest cause of hypocalcemia is hypoalbuminemia. So before you make any comment on anybody's serum calcium, you must know what the albumin is. Because for every gram decrease in serum albumin, you have to add 0.8 to the serum calcium. For every gram decrease in serum albumin below 4, you must add 0.8. So if somebody's albumin is 2 milligrams per deciliter, you have to add 1.6 to whatever the serum calcium is. That is now called the corrected calcium. If that is still low, then you say your patient has hypocalcemia. Okay, remember that. Another cause for hypocalcemia is vitamin D deficiency or vitamin D resistance. Okay? Now, I'm going to give you a clue that is important. I hope you remember it. Whenever vitamin D deficiency is the reason for low serum calcium, phosphate is also low. Okay, that is one quick and dirty trick. One of them will help you.
Can you say that again? Sorry.
Whenever vitamin D deficiency is the reason for hypocalcemia, serum phosphate is also low. Whereas in hypoparathyroidism, serum phosphate will be high when serum calcium is low. Okay? Then osteoblastic metastasis, like in breast and prostate. So these are bone-forming metastasis. Pancreatitis and anticonvulsant medications. Right? All of this will give you hypocalcemia. And then, what are the things that will give you hyperphosphatemia? They're right there. These ones, I just put it here for you to know. Somebody, you should be dealing with this in nephrology. Okay, so just in case you guys don't talk about it in nephrology, here it is. Causes of hyperphosphatemia, blood transfusion. Why do you get it after blood transfusion? Because the anticoagulant in stored blood is CPD, citrate phosphate dextrose. So that's how you get it. Infusion of phosphate. Nephrologists do it all the time. Right? Rhabdomyolysis. Tumor lysis syndrome. You did that, right?
Yes.
Yeah. And did Lindsay talk about this?
Yeah.
Good. Hemolytic anemia, renal failure, acidosis, toxic shock syndrome, enema phosphate, as in fleet enema. We talk about that in here, right? So all of those can give you elevated serum phosphate. You just need to know, be familiar with some of these. The good thing is that we don't routinely measure phosphate. The only time you actually measure serum phosphate is when your calcium is low. To kind of figure out what is going on. Okay? How do you diagnose hypoparathyroidism? You measure intact PTH and calcium level at the same time. Intact PTH and calcium level are measured at the same time. And how would you know you have hypoparathyroidism? Serum calcium will be low and PTH will be low. But as you can see, there is a reason I gave you this figure right here. As you can see, when your patient is down here, it is clear what this is, right? But your patient could be up here, right? Overlapping with normal reference area. So the number the best number will be in this quadrant here. But you could see that a significant portion of patients will be in this area, where the PTH is not as low as you expect it to be, right? Even though the calcium is low, right? So this is why one of the most difficult tests to interpret is PTH, because you have to measure it at the same time as the calcium level, and then you have to look at the chart. Usually the lab will tell you maybe normal, maybe high, when it is in this range. I'm just warning you, in exam, they will actually make it crystal clear. You will see low serum calcium and you will see low PTH, and you know that is hypoparathyroidism. But in practice, it is never that crystal clear. It overlaps with a bunch of other stuff. We'll talk about this down the road. So pay attention. Low serum calcium level should signal hypoparathyroidism and prompt you to order for serum phosphate and magnesium level. The measurement of intact PTH and calcium is indicated only after low calcium and high phosphate are established. You got that? Mm-hmm. So you don't go measuring intact PTH just because you see low serum calcium. No, first you order phosphate. It is only when you have established that the phosphate is high in a patient with low serum calcium that then you now proceed to order for intact PTH. Okay? And of course, the lab will always measure the sodium and potassium at the same time. Okay, so that's how you diagnose it. But there is something that you must think about every time you think about hypoparathyroidism. Anytime you think about hypoparathyroidism, you must think about pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism is a hereditary inability of the bones and kidneys to respond to parathyroid hormone. In other words, the patient is not really hypoparathyroid, it's just that the target organs are not responding to the PTH. So the patient will present exactly like somebody with hypoparathyroidism. The way you know it is that the PTH level will be high. Under normal circumstances, in somebody with hypoparathyroidism, you have low calcium, high phosphate, and low PTH. But in patient with pseudo-hypo, you have a high PTH in the face of low calcium, okay? Because the bones and the kidneys are not responding to the parathyroid level. Pseudo-hypoparathyroidism is a developmental anomaly. It is also associated with mental retardation, short stature, short toes and fingers. And the shortness of the toes and fingers is due to shortening of the metatarsals and the metacarpal bones. So this is how it looks. You look at the patient's feet, and you see the last two toes are really short. And then look at the hands, they're really short like that. Yes, Wendy?
I don't know if I misheard you, but
Yes.
So that means phosphate level can be low and high.
No, no, no. In hypoparathyroidism, calcium level is always low and phosphate level is always high. Right? Now, remember I told you, before you associate hypocalcemia to hypoparathyroidism, you have to exclude other causes of hypocalcemia. One of those other causes of hypocalcemia is vitamin D deficiency. And I said, whenever vitamin D deficiency is the reason for low serum calcium, phosphate level will be low at that time. Okay? So just to help you identify vitamin D quickly from hypoparathyroidism.
Oh, so that slide was just to show that those are the reasons why calcium will be low and
Yes,
phosphate.
yes, yes. That's why you notice I put double triangle. That means differential diagnosis of hypocalcemia and hypo. I explained that. Were you sleeping?
No, you said that about the two. No,
You didn't say that about the
This slide right here.
No, you didn't say the two triangles meant that.
Well, I've used it before. I thought you understood that this is a symbol. Double triangle generally means differential diagnosis. Oh, okay, good. Let me tell you many things we use. Symptoms. Patient complaint on examination, right? And I used to write this for assessment. Until somebody called me up. Why are you talking like the ass on your nose? I'm like, oh, that is assessment. So I changed it from assessment, and I will now do this. Right? It's not unique to me. It's standard symbols.
I thought he was using his own language.
But now, they changed it to soap, right? Right? But before soap, we used to be complaining of an examination and addresses, and then your treatment plan used to be written like this.
So that double triangle is universal. That's how you're going.
Yes, double triangle just means differential diagnosis of these conditions, right?
Yes.
Okay, I don't have time this morning, guys. All right, so in pseudo-hypoparathyroidism, not only do you have this weird picture, the patient has these characteristic skeletal abnormalities. Now, this is where medicine is crazy. Somebody now said, well, there are patients that have these skeletal abnormalities, but they have normal response to PTH. What do we call those? Are they okay? We call those people pseudo-hypoparathyroidism.
What the heck?
So, the presence of the developmental and skeletal abnormalities of Albright's hereditary osteodystrophy, which is what this is called, with normal serum calcium is known as pseudo-hypoparathyroidism.
That's the question.
Got that? I didn't make that one. I made that one. All right. So now let me tell you. Now this is one slide, one piece of information. You take it or leave it. You won't miss it if you don't take it. So you know now that hypoparathyroidism can be true or false, right? True and false hypoparathyroidism are difficult to differentiate when the characteristic developmental and skeletal abnormalities are absent. You see, when you have these abnormalities, it's easy to diagnose pseudo. But if they are absent and the PTH is within normal limits and your serum calcium is low and phosphate is high, how then do you tell hypoparathyroidism from pseudo? It becomes very difficult. There's one test you can do. You give the patient artificial parathyroid hormone and you collect urine and measure the count in the urine within 2 days, and you'll find out that parathyroid hormone will cause an increase in urinary concentration of phosphate and count within 1 to 2 days in patients with true hypoparathyroidism. It does not have any effect on pseudo hypoparathyroidism. Okay? That's just one piece of information. You might find yourself in that situation in practice. You know at least what to do, especially if in an endocrine practice. How do you treat hypoparathyroidism? Very simple. Just give calcium and vitamin D. That's it. You give calcium and vitamin D. You can give calcium IV in an emergency. If your patient is having Chivostek sign, Trousseau sign, complicated spasms, psychomoral paresthesia, all those acute manifestations, yes, you can give IV calcium. How do you give IV calcium? Pay attention. 10 to 20 mils of 10% calcium gluconate given over 10 to 20 minutes. Why do you have to be careful?
No, push it.
Why do you have to give it that slow? The heart. The heart, you will interfere with conduction in the heart and you can cause problems. Once you correct that acutely, you maintain with oral elemental calcium. And then you have to give them vitamin D. So how do you treat hypoparathyroidism? Calcium and vitamin D supplementation. There are two types of vitamin D. There is the plant-based ecocalciferol and there is the animal-based cholecalciferol. Animal-based cholecalciferol is more effective than plant-based. Notice that, Aaron? So plant is less effective than animal. Okay, remember that. Okay? And then the ultimate is really to restore what is missing. And now we have a recombinant human parathyroid hormone. It's called teriparatide. Awfully expensive, but it's available. I've never used it because my patients were never able to afford it. But what is fancy these days is you can send them to India to get auto-transplantation of parathyroid gland. You can, but it's unaffordable. Okay. So, yes.
For the vitamin D, when you prescribe patients that, you try to give them the vitamin D with K2.
With K?
With K2.
What is K2?
It's what it does, it helps the vitamin D go to the correct areas of the body. It's
you have a study on that one?
No, it's called menaquinone. It's MK7.
You're speaking in tongues, man.
I've done research.
I know.
I'll show you.
I know. Show me, maybe I'll learn something.
Yeah.
I was going to tell you this. Now, any question? You're good. Let me tell you the salient point of my lecture on this topic this morning. You must remember that low serum calcium and high serum phosphate is how hypoparathyroidism presents. But in order for you to attribute low serum calcium and high serum phosphate to hypoparathyroidism, you have to exclude the other causes of hypocalcemia and hyperphosphatemia. Okay? And I don't know if you noticed, the causes of hyperphosphatemia: blood transfusion, phosphate infusion, rhabdomyolysis, tumor-lysis, hemolytic anemia, renal acidosis, toxic shock, NMR phosphate. If you put them together, you spell birth rate. Okay? Okay? So, I can try and help you with that. Okay? Birth rate.
Sorry, we're speaking in tongues.
Huh?
You need to sit down. So you're in pain. Sit down.
Yeah.
You know? I misspoke when I was talking about auto-transplantation of the parathyroid gland. Auto-transplantation of the parathyroid gland is what the surgeon does when they want to go in and take out the thyroid. They go there and first of all, before they touch the thyroid, identify the parathyroid and remove it, right? Then they take out the thyroid and then implant back the parathyroid glands. We don't do parathyroid transplantation, but surgeons do auto-transplantation as a way to prevent accidental removal of the parathyroid. I'm so sorry. Yeah.
Take it out first.
Huh?
They put them in the wrist.
They can put them anywhere. They can put them back in the neck if they want.
No, I mean like they
It depends.
store them in the wrist while they take out the thyroid and then they put them back in. Is what we were talking
Say that
about. They
again?
take out the parathyroid, they place them in the wrist, and then they remove the thyroid and then they take them out the wrist and put
Put them back in the neck. Who told you that? Dr. Who?
Doctor
Oh,
Who.
yeah.
Okay, that's good. All right. So let's go to any question on hyperparathyroidism? Any question on hyperparathyroidism? You're good?
No.
Okay. So let's talk about hyperparathyroidism. That is excess parathyroid hormone. It could be primary or secondary, as usual. When it is primary, it means you have inappropriate PTH levels. When it is secondary, it means the PTH is actually trying to respond to something. Okay? So it is primary hyperparathyroidism when the PTH level is not needed, but the parathyroid is making it. And it is secondary when the PTH level is a response to something. Okay, and we'll talk about that later. Now, let's talk about the primary inappropriate one. 90% of the time, it is due to parathyroid adenoma. Right? Parathyroid adenoma. A parathyroid adenoma can be solitary, or it can be part of multiple endocrine neoplasia. Have you heard about multiple endocrine neoplasia before?
Yes.
Good. So I don't need to spend too much time on it. So when it is part of multiple endocrine neoplasia, there are three types. There is a type 1 where you have that adenoma associated with pancreatic tumor and pituitary tumors. And because it's tumors in three places, generally the way we remember it is says the 3 P's, right? 10% of the times, excess parathyroid hormone is due to parathyroid hyperplasia. 10% of the time. Okay? Again, parathyroid hyperplasia is usually part of multiple endocrine neoplasia of the second type. And the second type of multiple endocrine neoplasia has two subtypes, A and B. In the A, the parathyroid hyperplasia is associated with medullary thyroid carcinoma and adrenal pheochromocytomas, right? So because you still have parathyroid problem and a pheochromocytoma with medullary cancer of the thyroid, say 2P is 1M. I don't know if that helps, but it's out there. And this is the gene that is associated with that MEN2A, RET procogene. You see many textbooks who put RET. What the heck is RET? Rearranged during transfection with DNA from lymphoma cells. So this is a gene complex that when you take DNA from a cell with lymphoma and you inject it into the cell that has this gene, the gene rearranges itself in response to the presence of this DNA from lymphoma cells for whatever reason. And those cell types are known as RET proto-oncogene. I just want to define what RET is for you. And then there is multiple endocrine neoplasia 2B, where you don't have parathyroid hyperplasia. Please pay attention. Parathyroid hyperplasia is associated with MEN2A, period. I wanted to complete the picture by talking about MEN2B. MEN2B has nothing to do with parathyroid hyperplasia, because instead of parathyroid hyperplasia, they actually have marfanoid features and mucosal neuromas. Okay? And then finally, about 1% or less than that, excess parathyroid is due to parathyroid carcinoma. Okay? Less than 1%. And usually secondary to radiation therapy to the neck. Okay? Now, so this is when it is primary. Okay? Now, when it is secondary, that means it is appropriate. In people with chronic renal failure, they accumulate phosphate. And because they accumulate phosphate, the phosphates begin to couple with calcium and begin to get deposited in bones and soft tissues. That results in hypocalcemia. And then the PTH will respond to that by increasing. That's why it's an appropriate response, right? In addition, in somebody with kidney failure, they are not able to activate vitamin D. And because they are not able to activate vitamin D, they are not able to absorb calcium from their diet. And because they're not able to absorb calcium from their diet, serum calcium plummets and PTH goes up. So that is why the two main causes of secondary hyperparathyroidism is kidney failure and vitamin D deficiency. How do you get, yes?
Oh, sorry. If you're saying calcium and phosphate are binding together, then your serum calcium will decrease, or would it? Okay.
When you retain phosphate, phosphate couples calcium and they deposit anywhere. Not just in bones, they deposit anywhere in the body. And I will show you pictures where you have these abnormal calcifications. It's part of the manifestation of kidney failure. Many patients on dialysis, you see crystals coming out of their skin, calcium phosphate crystals. Then vitamin D deficiency is the second cause. How do you get vitamin D deficiency? Fat malabsorption. Because vitamin D is a lipid soluble vitamin, right? So when you malabsorb fat, you leach out vitamin D in your stool because you're not able to absorb it. You get trapped in the fat and get excreted. Okay, very important. Now, there is a tertiary hyperparathyroidism that is very weird. You know what we call tertiary hyperparathyroidism? When you have secondary hyperparathyroidism, where the parathyroid gland is enlarged and putting out a lot of PTH in an attempt to restore serum calcium. Normal response is an hyperplastic response. So the cells increase in numbers and they overwork to put out PTH. Occasionally, sometimes, a few of those hyperplastic cells will become malignant and develop into an adenoma. So that even when the serum calcium is now normal, the adenoma will go rogue and start putting out PTH, regardless what the serum calcium is. When that happens, we call it tertiary, what is called autonomous hyperparathyroidism. Okay? Huh?
You might say that again.
Okay. I told you that when somebody has chronic renal insufficiency or vitamin D deficiency, serum calcium will drop for a wide variety of reasons, right? The parathyroid gland will increase PTH. The attempt is to restore the serum calcium. And because renal failure is still going on, or malabsorption is still going on, the cells in the parathyroid gland, they will increase in number and they will also increase in function. It's a normal hyperplastic response. If that goes on for a long time, the hyperplasia becomes malignant or neoplastic, really. Not malignant, neoplastic. So instead of just staying hyperplastic, they become neoplastic. When a group of them become neoplastic, they form an adenoma. Now, the difference between an adenoma and hyperplasia is that the hyperplastic cells are still sensitive to negative feedback, whereas the adenomas are not. So they just go rogue, and they keep putting out PTH. Even when the serum calcium is now normalized, the adenoma is still putting out PTH, right? And that is what is called tertiary hyperparathyroidism, okay? So how does it present? It presents with hypercalcemia. Hypercalcemia. So, What are the symptoms of hypercalcemia? It could be neurologic, gastrointestinal, renal, or skeletal. Delirium, fatigue, muscle weakness, GI, nausea, vomiting, abdominal pain, peptic ulcer disease because of activation of gastrin, acute pancreatitis, constipation. In the kidneys, you get polyuria, polydipsia, you get kidney stones. In the bones, you get bone pains and swellings, you can fracture, deform, and you itch. One of the reasons that itching is more specific for secondary hyperparathyroidism because it's due to the calcium phosphate deposition. Now you see, look at this long list again. It's a long list of stuff. But the specific ones are really the bone pains, the constipations, and the stones. That's what they call it, bone groans and stones, right? You heard that before? Mm-hmm. Excellent. Okay. And then there is something that is interesting. You have this nail deformity called racket nail. You see that? And when hypercalcemia has been on for a long time, you get this opacification of the cornea in a linear sense from one angle of the eye to the other. It's called band keratopathy. Did you do that in ophthalmology?
No.
Okay, but now you know. Band keratopathy and racket nail are clinical features of hypercalcemia. Again, on EKG, what do you see here? See how short this QT interval is. It's almost fitting within one big box. You see that? And that is so not normal. Okay. Y'all see that? Okay. I put this here because I think it's important that you know it. Remember I told you that 90% of the time hyperparathyroidism is neoplastic. It's a tumor. It could be solitary or part of multiple endocrine neoplasia. You need to be able to know when to suspect multiple endocrine neoplasia. Okay? You need to know when to suspect multiple endocrine neoplasia. So, in somebody with, when your patient is young, under the age of 30, and there's a family history, you must, family history of hyperparathyroidism, you must consider the possibility of multiple endocrine neoplasia. In type 1, which is known as Weber syndrome, they have pancreatic tumor, they have pituitary tumor, right? Along with hyperparathyroidism, right? Usually a parathyroid adenoma. That pancreatic tumor can come from any pancreatic cell. If that pancreatic tumor develops from a beta cell, it is called an insulinoma. Your patient will present with hypoglycemia. Okay? So you will find a patient that was found unconscious, and then the paramedics was called and they did the blood sugar, and the blood sugar was 30. Now they gave the patient glucose, patient woke up. You admitted the patient, you now draw blood for routine blood test and find hypercalcemia. That is how that can present, right? So I can paint a picture of that, like that for you. If the tumor comes off of the VIP cells, vasoactive intestinal peptide cells, you call it a VIPoma. The patient will come with chronic diarrhea. Okay? If the tumor develops from the G cells, the gastrin-secreting cells, that will be a pancreatic gastrinoma. The patient will present with Zollinger-Ellison syndrome. Right? So you see, depending on which cells in the pancreas becomes neoplastic, the clinical features will vary. You got that? And then if it is a pituitary tumor, depending again on which cell, you can get acromegaly, you can get galactorrhea, you can get Cushing's disease with visual field defects. Okay? So this is how men one present. Again, this is men's too, known as Sippel syndrome. You find hyperparathyroidism, adrenal pheochromocytoma, and thyroid medullary cancer. Very important for you to be able to distinguish the presentation of pheochromocytoma from medullary cancer, because they both present in very interesting ways. And people get them confused all the time. The presentation of thyroid biliary cancer is what is called a carcinoid syndrome. Okay? They present with chronic diarrhea, peripheral flushing, right? And they can have cervical lymphadenopathy. That is not as specific. But pay attention, chronic diarrhea and peripheral flushing. Compare that to pheochromocytoma. They have palpitations and peripheral pallor. During the crisis, the patient is pale in pheochromocytoma. During the crisis in carcinoid syndrome, your patient is flushed. Very important. Pay attention, because this is all you'll be given. If anybody ever asks you this, flushing versus pallor is how you differentiate between carcinoid syndrome and pheochromocytoma. Of course, with pheochromocytoma, you also get labile hypertension. So somebody will come to you today with a blood pressure 220/120, and then the next visit, the blood pressure is 120/80. And you measure it with the same patient, the same machine, and blood pressure is swinging like that, okay? Again, the diagnosis of hyperparathyroidism is based on hypercalcemia and hypophosphatemia. Okay? Hypercalcemia and hypophosphatemia, the opposite of hypoparathyroidism. But before you attribute hypercalcemia and hypophosphatemia to hyperparathyroidism, you must rule out other causes of hypercalcemia and other causes of hypophosphatemia. Look at the causes of hypercalcemia. These are very important. You should really try to remember this. Okay? Hypercalcemia you can get from vitamin D and vitamin toxicity, vitamin D or vitamin A toxicity, and this is common. I've seen this many, many times, usually in patients that are taking supplements. You know, I have patients that take Centrum, they take vitamin D with calcium, they take this supplement, that supplement, and they are not fully aware of all the ingredients in those supplements. And then they end up with these vitamin toxicities. All right? And then osteoblastic bone metastasis, lymphoma, leukemia, breast cancer, multiple myeloma, immobilization. If somebody has been sitting down or being in bed reading for a long time, they can develop hypercalcemia, especially if they have an underlying Paget's disease. Just remember that. We'll talk about that sometime down the road. Okay? Thyrotoxicosis can give you little hypercalcemia sometimes. Addison's disease, because of low filtration and high reabsorption, again can give you hypercalcemia. And then sarcoidosis. In sarcoidosis, you can get hypercalcemia because in the sarcoid granulomas, you can have 1-alpha hydroxylase that activates vitamin D. Okay? And then there's a bunch of medications. Antacids, Accutane, lithium therapy, and thiazide diuretics. These are all medications that can cause hypercalcemia. If you see what I put here, it spells vomitus, right? Vomitus. Yeah, the vomitus and the medications spells malt. Vomitazine? Well, whatever works. Right? Vomitazine. Vomitus. What is vomit in Spanish?
Or you can do sand vomit.
Vomito?
Oh, vomit. Okay, we need to look for a way to make it vomit. All right. Okay. And then look at the causes of hypophosphatemia. Intracellular shift, in acute respiratory alkalosis. You know what happens, right? In respiratory alkalosis, the body tries to respond to the pH going too high, and the way it does it is by stimulating lactic acid production through the glycolytic pathway. And that pathway requires phosphate, right? So phosphate is taken from this blood into the cells, and that's how you can precipitate hypophosphatemia. You can get hypophosphatemia from reduced intake in patients with malabsorption of antacid therapy. Many things used for antacid will bind phosphate. And then increased output, as in Fanconi syndrome or saline diuresis. You talk about all this in nephrology. I'm just giving you extra, just in case. People don't talk about these things, you will know what I'm talking about. Again, don't get confused. This green and this, whatever this color is, purple, has nothing to do with hyperparathyroidism. I'm just giving it to you. Isn't this purple?
It's pink here.
That's a pink.
Pink? This is pink?
Yes.
Purple on the green.
It's
But
purple.
it's kind of like purple, it's green.
Purple.
Whatever. But this is green, right?
Yeah.
Yes.
And this is yellow.
Yes.
Good.
Well, not him stand.
The green and the pink have nothing to do with hyperparathyroidism. No, I put them there to help you know that before you can attribute hypercalcemia and hypophosphatemia to hyperparathyroidism, you must exclude these other things. Okay?
Okay.
Again, how would you make the diagnosis ultimately of hyperparathyroidism? Once you suspect hyperparathyroidism based on high serum calcium and low serum phosphate, then you will measure intact PTH and calcium levels at the same time. Okay? And again, what are you looking for? You're looking for elevated calcium in the presence of high PTH, which will tell you that is a primary hyperparathyroidism, right? But if it is due to renal failure, what would you have? You will have low serum calcium and a high PTH. It will be in this corner right here. Are you following me? That's how you read this chart, right? If it is due to malignancy, in other words, your calcium is high because there is a bone-breaking metastasis. Your calcium will be high, but your PTH will be low. So you'll be active. So you understand how to read this now, right? Right? I don't need to go over it, do I? Excellent. Now, what are the tumors that you need to be familiar with that can actually cause bone-breaking metastasis? Look at them. Bladder cancer, renal cancer, ovarian cancer, uterine cancer, skin cancer, squamous cell cancers of the tongue, esophagus, larynx, and lung. And then, you know what? You know how they do it? Some of them, they do it by metastasizing to the bone and stimulating osteoclastic activity. Others of them do it by releasing another peptide that looks like PTH, but it's not exactly PTH. We call it PTH-related peptide. Okay? So that is the mechanism by which the tumors can cause hyperparathyroidism. Now let's take a look at this picture right here. But before I move on, I want you to remember that when we're talking about hypoparathyroidism, I told you before you establish, anytime you establish a diagnosis of hypoparathyroidism, you should exclude pseudo-hypoparathyroidism. The same thing is true in hyperparathyroidism. Anytime you make a diagnosis of hyperparathyroidism, you must exclude something. Most patients with primary hyperparathyroidism will present with a mild asymptomatic hypercalcemia. So don't wait for the bone growths and pains and all that stuff, stones, to make a diagnosis of hyperparathyroidism. That is not how you want your patient to present. Most of the time in the clinic, all you will see is a mild elevation in serum calcium. But don't be too quick to make the diagnosis of primary hyperparathyroidism based on mild elevation of serum calcium. There is another condition that is more common, known as familial benign hypocalciuric hypercalcemia. So there is this condition that runs in families. It doesn't kill people, but it impairs their ability to excrete calcium and causes the calcium to back up into their blood. And we call it familial benign hypocalciuric hypercalcemia. Now, what is it? It's an autosomal dominant loss of function mutation. You know what that is, right? You know mutation, there are two types of mutation. There are mutations that inactivate the genes, and there are mutations that make the gene hyperfunctional. When a mutation inactivates a gene, we call it loss of function mutation, right? So, FBHH is a loss of function mutation of the calcium sensing receptor gene in the kidney and the parathyroid. So because the calcium sensing gene is blind, it senses normal serum calcium as low. So calcium is there, but the sensing mechanism is not seeing it. So it keeps sending signals to the PTH cells like calcium is low, even though calcium is low, right? And then that leads to release of PTH. Renal calcium is absorbed, reabsorbed, and renal calcium excretion is reduced in the urine. So how do you quickly eliminate this? Just do 24-hour urine calcium, or you collect a spot urine and look at the ratio of calcium to creatinine ratio. It should be less than 0.01. If the calcium creatinine ratio in a random urine sample is less than 0.01, you have familial benign hypocalciuric hypercalcemia. Okay? So that is how you quickly knock that out. I just want to make sure I say that and that you understand it. So let's take a look at everything together. So considering everything together, when you have primary hyperparathyroidism, your phosphate will be low, right?
Yeah.
Your PTH will be high. Your PTH-related peptide will be undetectable because you have primary hyperparathyroidism. It will be undetectable. Your serum calcium, your serum vitamin D will be high, and your urine calcium will be high. Usually, pay attention, because this is very similar to the situation where you have abnormal TSH and normal total T4 or free T4. Under normal circumstances, your urine calcium should track your serum calcium. When that is not the case, something is wrong. Just remember that. If somebody has malignancy-associated hypercalcemia, they will have low serum phosphate, because remember, that is mediated by PTH-related peptide. It will do everything PTH does, right? So they will have low serum phosphate, but instead of PTH, they will have PTH-related peptide. So PTH itself will be low, but the PTH-related peptide will be high, and everything else will be just like that. One thing that PTH-related peptide does not do is to actually activate vitamin D. Okay? Now, see what happens when somebody has familial hypocalciuric hypercalcemia. Everything is normal except urine calcium. Because remember, it's hypocalciuric hypercalcemia. The reason the serum calcium is high is because of the reduced calcium excretion in the urine. Okay? Huh? In familial hypocalciuric hypercalcemia, your patient is a normal patient with this condition that he inherited. So phosphate is normal, PTH is normal, PTH-related peptide is undetectable, serum vitamin D is normal. The only abnormality is the urine calcium. that is low. Okay? And when somebody has a vitamin D toxicity, everything, PTH of course will be low because of increased calcium. Vitamin D, urine calcium will be high because of serum calcium is high. And serum phosphate is high as well. Okay? Now, remember I told you that in vitamin D deficiency, calcium is low and phosphate is low. In vitamin D toxicity, calcium is high and phosphate is high. Okay? The opposite is also true. Good. Let's see now. Okay. Let me ask you, how are you feeling? Are you near saturation point? Yeah, I could see. When you go quiet, there is trouble. So, we're almost done, right? And I have some questions that will help drive this home. I want you to ask me questions. If you have any questions, anything you want me to repeat, I'll repeat it. I've done my best to help you with some questions that we're going to do later on, but I don't want to, I need you to be able to attend to those questions and hopefully get them correctly. Are you clear with everything so far? Yes, go.
The column of the serum vitamin D, I didn't quite get how to use it to differentiate.
Say it again.
The vitamin D column, I didn't quite understand for the last slide.
Right here.
Yes.
I said PTH related peptide does everything PTH does except stimulate vitamin D, 1-alpha hydrogenase. So it does in primary hyperparathyroidism. This is PTH is high, phosphate is low, PTH related peptide is undetectable, but 125 hydroxy D is high because of the activation of 1-alpha hydrogenase. If you compare that to malignancy associated, you don't have that because PTH related peptide does not activate 1-alpha hydroxylase, right? And then the other point I want you to remember is that vitamin D dependent hypercalcemia is also associated with hyperphosphatemia. So now, let's say you have done everything you need to do and you now established that your patient does in fact have hyperparathyroidism. You now send them to do sestamide scan. It's a technetium 99 sestamide. And sestamide just means that they use a coordination complex of technetium 99 and 6, that's why it's sesta, right? Methoxy isobutyl isonitrile ligand, MIBI. You don't need to bother yourself with this. I just put it here for your reference. What we normally say is you send the patient for sestamide scan. What are we looking for? We're looking for the tumor. You only need to do this after you have established that the patient has primary hyperparathyroidism. Because remember, 90% of the time there is an adenoma that you're looking for. Remember that. Okay? Can you do other stuff? Well, you can do ultrasound if you want. If you're happy with 79% sensitivity. If you're okay with missing 1 out of every 5 cases, you can do ultrasound. I know you don't want to do that. And CT scan and MRI is even worse. So MIBI scan is really the best. Okay? How do we treat this stuff? It depends. If your patient is symptomatic, you want to acutely control the hypercalcemia. How do you do that? You do saline diuresis. So you give them like high flow saline infusion, provided the kidneys are fine. If the kidneys are not fine and you do that, you put your patient in heart failure in no time, right? So you give them high flow saline and you give them Lasix. Why do we do that? When you give somebody saline and Lasix, you increase urine flow in the tubules. and there is no time to reabsorb this calcium, so you get washed out in the urine. That is why it is called saline diuresis. And then you give them what is called bisphosphonates. And bisphosphonates are basically short-term calciuretic. They make you pee urine, and then they also divert the calcium to the bone. So they have this palmidronate and zoldronic acid. Your goal is to do whatever you can to keep calcium under 12. Okay? Bisphosphonate, they increase calcium excretion and they inhibit the deposition and the breaking of the bones. Okay? So they facilitate the deposition of the calcium in the urine. And of course, what is the ultimate treatment? Take the thyroid adenoma out. When would you do this? When the patient is symptomatic, the patient is pregnant, the kidneys are getting compromised, bone disease is beginning to be severe, so you have a T-score, bone mineral density T-score less than negative 2.5, and your patient is young, less than 50. Now, what if your patient is not symptomatic? So you just see simple elevated calcium, and you did all the workup, and you end up with a diagnosis of hyperparathyroidism, but the patient is not symptomatic. Again, you give them liberal fluid intake, regular exercise. If they are taking any antacid, lithium, diuretics, you stop all those, and you monitor their bone density, okay? And you prevent bone reabsorptions. And all these medications here are good for preventing bone resorptions. Estrogen, you may give you cancer. Then you have these selective estrogen receptor modulators, like raloxifene. You can use oral bisphosphonate like alendronate. And you can, this is what everybody wants to give, Sensipar. But it's so expensive. Sensipar is very, very expensive. But it's a calcium mimetic, also known as sinacalcet. Remember the names? The way it works, it lowers parathyroid hormone levels by binding and sensitizing the parathyroid gland to serum calcium. So it makes the parathyroid gland more sensitive to the serum calcium, so it can do what it needs to do to bring it down. Okay? So that is the treatment of primary hyperparathyroidism. What about secondary hyperparathyroidism? It depends on what is causing it. I told you only two things cause it, right? Renal failure and vitamin D deficiency are the only two causes of secondary hyperparathyroidism. Right? Remember type 2 respiratory failure? What are the two causes of type 2 respiratory failure? Hypoventilation and COPD. These are the only two causes of type 2, right? This is another situation. Only two causes of secondary hyperparathyroidism. Chronic renal insufficiency and vitamin D deficiency. Okay? You have to help yourself remember by associating things like this across different classes. That way you keep some reasonable knowledge of stuff with you handy. Okay? So, if it is due to renal failure, after dialysis, they give them calcitriol, right? He works by suppressing PTH and he raises calcium. You monitor their calcium and phosphate product. Why do you monitor calcium and phosphate product in patients with chronic renal failure? Because remember, in chronic renal failure, you have hyperphosphatemia and hypocalcemia. When you begin to raise serum calcium, you're likely to make the complexing of phosphate and calcium worse. And that is going to happen whenever your calcium phosphate product is more than 55. So that is why in chronic renal failure, you monitor what is called the calcium phosphate product. With your treatment, you want to make sure the calcium phosphate product stays under 55. If you don't do that, you begin to form calcium phosphate crystals in your patient's skin like this. And that's why it can cause a lot of itching. Okay? So, whenever the product is more than 55, you lower the dose of calcitriol. You can switch to sinacalcet, or you can just give vitamin D analogs. because they're cheaper anyway and they work just fine. And if it is due to vitamin D deficiency, give vitamin D. That's it. What is it? What is cancer? Right? There are only 3 causes of hyperparathyroidism, remember? Adenoma, the primary one is hyperplasia, adenoma, cancers, right? And then the secondary ones is chronic renal failure and
Vitamin D
vitamin D
deficiency.
deficiency. What if you're dealing with parathyroid carcinoma? You have to take it out. That's the end of the story. Adenoma and carcinoma, take it out. How can you suspect carcinoma from the get-go? Anytime you have a neck mass with a serum calcium above 15 milligram per deciliter and PTH above 5 times the upper limit of normal, you don't even need to waste your time trying to walk the patient up or understand the patient. Send the patient out straight to endocrinologist. They will work with the surgeon to take care of the patient. Because almost always, when your serum calcium is more than 15 and your PTH is more than 5 times the upper limit of normal, you have parathyroid carcinoma. And the treatment is unblock resection of the tumor. And this is just unnecessary details, but for those of you that care about it, once you do resection, you always send the sample to the lab, to the pathologist, to make sure the margin is negative. If the margin is negative, that means you got all the cancer. If the margin is not negative, then your surgery was not curative. You have to now do other stuff like adjuvant radiation therapy and stuff like that, right? You see this side over here? I'm not going to talk about it because it's easy, but it's a little bit complicated. I don't want to complete this case. You guys are like almost confused right now. And it's not really important. It has to do with the fact that the technique for measuring PTH has changed. We used to measure intact PTH, but now there is this new system that measures the active PTH called the amino PTH. And the ratio of the old and the ratio of the amount of PTH by the old and new technique is sometimes helpful in determining how well your patient will do after surgery. So that one you can put a question mark there. Read it if you understand it, good for you. If you want to understand it after your midterm, come to me. We can talk about it. But it's one of those things I want to remember it. That's why I put it there. Okay, so it's not for you. Remember I told you when you take the tumor out, you've had this parathyroid tumor that has been leaching the calcium out of the bone, making the bone very brittle. All of a sudden you take out the tumor and the PTH level goes down. When the PTH level goes down, the bones begins to recover immediately. They want to rebuild. And they do it very aggressively, right? They do it very aggressively and they begin to pick up the calcium from the blood. But remember that you've had an adenoma that has been pouring out PTH for a long time and increasing the serum calcium level. That same adenoma, that adenocarcinoma that was increasing the serum calcium level by increasing the PTH, had been suppressing the normal parathyroid tissue around it. So when you take it out, you now leave the patient with bones that are aggressive and normal parathyroid tissue that are recovering. So even when the bones bring the calcium down and below, because the normal parathyroid tissue are still recovering from the prolonged suppression of the PTH from the cancer, the patient goes from hypercalcemia to hypocalcemia. And that clinical complex is what we call hungry bone syndrome. Aggressive skeletal remineralization followed by relief. hypocalcemia. So you go from hypercalcemia to hypocalcemia, hypophosphatemia, and all that. All right. So let's go through some of these questions. Any questions? Well, I have questions. Let's do this as a group quickly. Mucosal neuromas, right? Type 2, right? E. Visual field defect, long QT,
Hypo.
okay. Metastatic calcification, short QT. Good. Which of these two patients is more likely to have a normal serum calcium? This one or this one? The one in the hospital or the one with the ring?
The one with the, isn't it the pseudo?
Who is more likely to have a normal serum calcium?
The top one.
The first one, exactly. You could see the capillary spasm here, right?
Yeah.
So that means that is the sign of hypocalcemia, right? Huh?
True. Yeah.
First sign, exactly. All right, let's see this. So here you have low PTH. Wait a minute. You have this question, you have the answers, right? Okay, you want to go over it?
Yeah.
Okay. So you have, we're going to do it together. So you have low PTH, low serum calcium, high phosphate, and low urine calcium. Remember I told you, under normal circumstances, serum calcium and urine calcium should match. If your serum calcium is high, your urine calcium should be high. If your serum calcium is low, your urine calcium should be low. Whenever there is mismatch, you must look for familial benign hypocalciuric hypercalcemia. Right? So in this case, everything matches. PTH is low, calcium is low, phosphate is high, and uric acid is low. What do you think is going on here? So what is going on here? PTH is low, that means it's hypoparathyroidism, right? The question is, is hypoparathyroidism, right? Talk to me. We're reasoning. I don't want you to just know the answer. I want you to know why the answer is the answer, right? If PTH is low, that tells you why calcium is low, right? And that tells you why phosphate is high, because you can't leach it from the bone. You don't have the PTH to do it, right? So this is hypoparathyroidism. How about this one? PTH is high. PTH is high, but calcium is low and phosphate is low.
Vitamin D.
Thank you. Exactly. You see, you have to recognize that pattern, right? Low means vitamin D problem. When they are flipped, it's a parathyroid problem. Okay? Just recognize that. I'm glad you got that. How about this one? High PTH, low calcium, and high phosphate, and high urine, whatever, urine calcium, right? Okay.
Hyperparathyroidism.
No.
Oh, because the serum is low.
You expect the
So let's think it through. PTH is high, right? Calcium is low, phosphate is high, but uric calcium is high. Why is uric calcium high in the presence of low serum calcium? Is that normal? What does this mean? PTH is supposed to cause increase in serum calcium, but it's not working. It's supposed to increase urine calcium absorption, but it's not working. What more evidence do you need for pseudo, right? I mean, is it, can't you see? You have high PTH, but it's not working. It's not doing what it's supposed to do, right? Why would you have low serum calcium and high urine calcium when you have a high PTH, right? Are you with me?
Yeah.
In the fourth case, high PTH, high serum calcium, low phosphate, and high urine calcium. So what is that?
Hyperthyroid.
Thank you. And in the fifth case, high PTH, low serum calcium, high phosphate, and low that.
So it's familiar because you said it was opposite.
No.
PTH.
Oh.
You said if it was high PTH or opposite P.
No, he said the
wait.
calcium.
Calcium.
Oh,
The
that's
serum
right.
and
That's
urine.
right.
And I said the
So we're on the fifth case, right?
Yeah.
So PTH is high, calcium is low, this is low, and this is low. So PTH is doing something here, right? For sure, it is keeping the urine low, right? So what is this? Secondary hyperparathyroidism, right? So that tells you this PTH is responding to something, right? How about this one? Exactly, this is familial hypocalciuric hypercalcemia, right? So, good luck. Just practice. You have a whole week to do it. I'm so happy I caught up. I was worried. Any question? I know it's a lot, but because ordinarily this was supposed to be 2 separate lectures. But I didn't finish the thyroid disorder, so I had to combine it with the parathyroid, so it's a lot. But it's pretty straightforward. You just have to kind of take time, study it, understand it. Okay? All right.